Good afternoon, everyone. I'm Serena Collado, Director of Community Health at Robert Wood Johnson University Hospital, Somerset. Welcome to today's webinar on COVID protection, boosters and pills, presented in collaboration with Friends Health Connection. Over the past 2 years, scientists have gained a better knowledge of the COVID-19 virus, which has led to advances in prevention and treatment. During today's webinar, we will learn more about those advances, including booster shots and antiviral pills. We are pleased to be joined again by Dr. Ron Nahass, an infectious disease specialist and hospital epidemiologist for Robert Wood Johnson University Hospital, Somerset, who has been our trusted source for information about COVID-19 through the pandemic. So thank you again for joining us this afternoon. We are going to begin today's webinar with a moderated discussion followed by questions and answers from our audience. If you do have a question for Dr. Nahass, please post it in the Q&A section of this webinar. It allows us to see your question and not have to sort through the chat. You can use the chat for comments and shared information. So again, Dr. Nahass, thank you again for joining us. We appreciate it. We know how busy you are and have been. So again, could you maybe just first start for members of our audience who may not be familiar with you, telling us a little bit about your background and your role at the hospital during the COVID-19 pandemic?
Yeah, sure, Serena, and thank you again for having me. Always good to get on and talk to folks and answer some questions. So I'm an infectious disease doctor by training. And I am the hospital's epidemiologist. So that means that I work with other team members to help evaluate not only how we're responding to the pandemic, but also thinking about and working to protect people, patients, staff from getting COVID. I've also been the medical lead for developing treatment protocols at the hospital throughout the COVID pandemic.
That's great. Well, and thank you. I know you've been such a tremendous support to our team here and for our community as well. So over the past 2 years of this pandemic, we've seen individuals develop a severe infection from the COVID-19 virus, while others have had no symptoms and don't even know that they've had it. So what have we learned about the immune system that contributes to this vast range of responses to COVID?
Yeah, that's a great question, Serena, because so much of what happens and what we experience as clinicians and frontline providers is in dealing with the body's immune response to this virus. So as you alluded to, a number of patients, many patients, in fact, 20 to 30%, may have no symptoms when they get infected with COVID. And we don't fully understand that, whether it's, in fact, their immune system, whether it's a genetic predisposition, whether it's prior infections with related coronaviruses, the family of viruses that cause COVID, that limit the symptoms. It's not really understood, but what we do know is that those individuals who get very sick and very ill, particularly those who end up in intensive care and are really struggling to survive, that's as a result of the body's immune response, fighting the virus to try and get rid of it. And it's really a dramatic impact. And we've learned over the last 2 years that we need to employ certain drugs that actually influence the body's immune response, blunt it down to try and help patients survive that immunologic onslaught, if you will.
And thank you for clarifying that. So then what is the role of autoantibodies?
Well, that's a really complicated question. And so there are a lot of parts to it, but let me see if I can try to unpack it a little bit to make it easier to understand. So autoantibodies are generally thought to be antibodies that are attacking the body. But in this particular case, as we think about COVID, these are antibodies that actually attack the virus and then induce an immunologic response. And so in the human body, when we have immunologic activities, we can have what we call inflammatory reactions that go amok, they go awry, and they cause all sorts of havoc. And that havoc is in the form of an inflammatory response, and they're induced by the autoantibody, or really they're induced by antibodies against the virus in this case. And it's a dysregulation. That the medical term we use for that is a cytokine release storm. So these antibodies induce an inflammatory response that cause the release of chemicals in the body called cytokines. And those cytokines are what make us so very sick, should we be one of the unfortunate people who develop this problem. And so the autoantibodies are the things that actually start the cascade. We call it a cascade. And you want to keep that from happening. That's really the goal of therapy when we're treating people.
Wow. So what does that say for somebody who's really sick then with the autoantibodies? Does that mean that it's one person may be weaker than others? Can you just clarify that?
Yeah, well, it doesn't mean that they're weaker. What it means is that they have developed a more vigorous cascade, remember I use that term, that initiated this inflammatory response that caused the cytokine storm. What does that result in? It results in severe dysfunction of a lot of the internal organs of the body. It results in terrible trouble breathing, sometimes to a point where you need a ventilator. It can result in, you've heard a lot about the issue of myocarditis related to the vaccines. Myocarditis from the disease, from the virus itself, is far worse because of this cascade and this inflammatory response that starts because of these antibodies. And so whether it's myocarditis or lung disease or disease of the brain, disease of the bone marrow, which produces our white blood cells, disease of the liver, all of these organs can be affected by this cascade that gets started by these antibodies. So we really want to try, what we've learned really, is you want to try and stop that from starting up front. The sooner you can intervene, the more likely we are to be successful. And we've learned that over these last 2 years.
Well, and definitely, and 2021 was definitely the year of the COVID vaccine. So can you give us an overview of how the vaccine works?
Yes, it was. I mean, we all started getting our vaccines a little bit over a year ago now. And boy, it was an amazing accomplishment that was enabled really by a lot of work that was done on SARS-1. Most folks aren't aware of that, but you hear a lot of criticism. It came across quickly or too fast or whatever. It actually wasn't all that fast, because it turns out the work that was done for SARS-1, the earlier, if you will, version of SARS-2, which is what's causing COVID, that happened 10 or 15 years ago. So we built on that and we developed all these amazing vaccines. And so this past year in the US, we had 3, 2 of which were called mRNA vaccines, and 1 of which was called a viral vectored vaccine. So the viral vectored vaccine was the J&J vaccine, and the mRNA vaccines were the Pfizer and the Moderna vaccine. And the basic premise of these vaccines is that they get the body to produce an antibody in response to the vaccine by getting our cells, our own body's cells, the machinery to produce this spike protein that we've heard so much about. So you get the vaccine in your arm, your body goes to work producing a spike protein for a short period of time. That spike protein can't make you sick. You get some side effects from the vaccine. It lasts a day or 2. We've all experienced that, but you don't get COVID. But that spike protein causes an antibody in your body to be produced. That antibody then is there to do what it needs to do, which is to protect you from COVID or getting seriously ill from getting COVID. And so that's how those vaccines work. They're extraordinarily effective, way more effective than any of us would have expected or anticipated. And even with Omicron, which, there's been a lot of discussion about that, the vaccines are extraordinarily effective in preventing serious illness. Frankly, in the hospital, what we're seeing, which is really an amazing experience, is that although we're seeing enough folks who come into the hospital with COVID secondary to Omicron who've been vaccinated, they're not very ill, and they're in the hospital only for a short period of time. The people who are in our ICU and sick in general are those who are not vaccinated or who have been vaccinated but have some underlying illness that prevents the vaccine from doing what I just described. And so generally, it really is truly extraordinary a year into this, that this vaccine, which was developed against what's called the ancestral strain, the original strain of COVID, is still protecting all of us from serious illness and death. It's really a remarkable accomplishment.
Great. So now, after millions of doses of the vaccines that they've been administered worldwide, what have we actually learned about the safety of the vaccine? And I know you just touched a little bit about it, but what else have we learned?
Yeah, well, actually, Serena, we've had billions of doses of the vaccine given now. It's estimated that somewhere around 2 to 3 billion doses of vaccine have been given. So when we talk about the numbers of doses, it's no longer in the millions, it's actually in the billions. It's quite extraordinary. In the US, we're in the range of 400 million to 500 million doses of vaccine have been given. So almost 500 million doses in the US alone. It is amazing. It is, I describe it as the largest biology experiment ever done, you know, so to speak, because so many people over such a short period of time got the vaccine. And really, it is strikingly safe. And the examples that I use as it relates to safety, and it's not to say, you know, when I got my vaccine, I felt like crap for a day. There's not a question that a lot of people don't really feel all that well. And that's true for a lot of vaccines. I actually felt worse when I got my shingles vaccine than when I got my COVID vaccine. But a lot of vaccines make you feel kind of crummy for a day or two. That's usual. But in addition to that, that sort of achiness, in general, though, you have no real significant symptoms. So when we looked at it over the last year now, the risk for something like Guillain-Barré, for example, is really small. In fact, Guillain-Barré, which is associated with vaccines of other types, is not a contraindication to getting the COVID vaccine because we learned that that's not an issue with the COVID vaccine. The issue of the myocarditis, which I mentioned earlier, which is this heart inflammation, just recently they published a new publication just this week, in fact, on it. And they've identified the risk of myocarditis being less than 1 in 100,000 doses. That's a really tiny rate. And myocarditis does occur with other vaccines as well. But myocarditis from COVID is far worse. And if we go back and we look just at the patients that we see in the hospital with COVID, and Lord knows there's been a lot of them, I can't tell you that I'm aware of or that I've seen a patient admitted to the ICU after a vaccine. I just haven't seen it. Yet millions of people have gotten the vaccine. And we see thousands of people who've been admitted to ICUs, hundreds of thousands of people. So, you know, that alone is a telling story. We've got, you know, I think it's estimated around 200 million people in the US, 250 million people in the US who've been vaccinated. And we're not seeing hospitals overrun with people being admitted after the vaccine. And you're not seeing people in the ICU after getting the vaccine. It's an extraordinary, if you will, like I said, experiment. We just don't see that happen, but we see it happen every day with COVID. And so it's an extraordinary statement of the safety of the vaccine. And it really is an amazing observation that we've been able to make.
So I want to just go back to something you have mentioned. You have mentioned that, you know, a lot of people get symptoms after they get the vaccine, but I've also heard from many community members saying, you know, I got my vaccine and I didn't have any symptoms. I didn't, you know. So again, what's the disparity here? Why are some people feeling some side effects from the vaccine and why are some people not?
Human nature. And so, you know, I like I said, you know, my reaction to the shingles vaccine when I got it was pretty severe, more so than the COVID vaccine. And, you know, you talk from patient to patient and, you know, my brother, similar genetics to me, when he got his COVID vaccine, he had no reaction to it. And he called me to say to me, gee, I don't think it's going to be effective. I got no reaction. Well, that's not really true. And so we know that there's just the human biology. It's the nature of the human immune response. The vigorousness of your reaction doesn't necessarily predict a more effective response to the vaccine, nor does the absence of a response to the vaccine, a side effect, mean that you're not going to be protected. That's just not true. It's the experience of human biology. It varies from person to person, where each of us are unique. and each of us will respond differently. And so I think the goal here is to make sure you get your vaccine. Don't use or don't be guided by the severity of your reaction. That actually has nothing to predict whether or not you're better or worse protected. It's irrelevant. It's just biology.
Okay, so now going back to this most successful biology experiment, as you mentioned. So what was the goal of this vaccine? Was it to prevent serious illness or versus mild illness? Can you expound upon that?
Yeah, I mean, you know, depends on how we look at the vaccines. You know, in the particular case for COVID, the real goal of the COVID vaccine was to prevent the serious illnesses that were driving hospitalization and really stretching us in a way that was going to make it almost impossible for us to care for patients, because we just don't have enough caregivers, don't have enough hospitals, and the amount of devastation would be just even more horrific. And so the goal of the vaccine when it was started was, the idea was to really limit the severity of the disease so that we did not have hundreds of thousands of people succumbing on a regular basis. A secondary goal of the vaccine was to prevent or limit infection. Now, it turned out that the initial vaccine, we call that the vaccine raised by the ancestral strain, turned out to be not so bad in preventing infection, although that wasn't the primary goal. And in fact, the ancestral vaccine that was developed and we all got was pretty good through Delta in preventing infection. And it was outstanding in preventing serious disease. You just didn't see it. With Omicron, it's a bit different. It's not it's not as effective, in fact, not that effective in preventing actual infection. It reduces it a bit, but not in the dramatic way it did with the other variants that we've experienced throughout the pandemic. But what it is awfully good at with Omicron, which is really, you know, thank God, is in preventing serious illness, as I just alluded to. So at the moment, our goals and our expectations from the vaccine are to really limit the severity of the infection so people don't end up in the hospital sick and ill. I will tell you that, you know, we've seen plenty of over this wave of Omicron, even though they talk about it being a mild disease. We've seen plenty of people in their 40s, 50s, or 60s who are unvaccinated ending up in the ICU. So it's the human biology. You don't know. Are you the guy or girl who's not going to get vaccinated, who's going to get Omicron and be the one who gets really sick? You cannot know that. And a couple of the folks, a number of the folks, not even a couple, a number of the folks that we've seen who have chosen not to be vaccinated got very sick with Omicron. It's terrible. It's tragic because that shouldn't happen. So principal goal, prevent serious illness and death. That's the principal goal, hands down. Secondary goal, prevent infection and secondary infection.
So I just want to tag onto something you said again. So why was Delta, the vaccine, so effective against Delta in preventing infection and not with Omicron? What's the difference? The variant, or are we talking the human factor again?
And no, it is the variant. And one of the things that's unique about all microorganisms is that they make many copies of themselves in a rapid period of time. That's why we get sick from bacteria or viruses. And when they do that, they make mistakes in making copies of their genetic material. And when they make mistakes of their genetic material in copying their genetic material, that's when a variant develops. And a variant changes its surface a little bit, its appearance, its antigens. And when that changes, that can evade the immune system. And so Omicron has a lot of mutations because when it made copies of itself, it didn't make exact copies, so it mutates. And those mutations allow it to evade the immune system better than Delta. Delta actually evaded the immune system better than Alpha, which was the variant before it. And Alpha did a better job at evading the immune system than the ancestral strain. So sequentially, the variants become more effective at evading the immune system by making mistakes, mutations. in how they copy themselves. So it is really about the virus, not the human factor, that allows the virus to avoid being successfully controlled from an infection point of view by the vaccine.
Okay, so then having said all that, how effective is the vaccine and how long is the protection going to last?
Well, again, at this particular point, the vaccine really still looks quite effective, amazingly so, as it relates to serious illness. And just this past week, the CDC published some additional data. One of the challenges with all of this is the data is ongoing as we're all participating and watching this biology experiment that we've been talking about. And so it really still looks amazingly effective, near 90% plus in preventing serious illness and death. So that's a really effective vaccine as it relates to the seriousness of this disease. This disease is the worst experience of my clinical career as it relates to the amount of death, amount of serious illness, and the vaccine is still 90% effective, even with Omicron. That's extraordinary. And how long is it going to last? We don't know that yet. Not enough time has passed. We need more time. I think we all are expecting that at some point we may, for the time being, we're going to be needing an annual vaccine dose, kind of like we get the flu dose. Mm-hmm. So probably an annual flu/COVID shot. But at the moment, we just don't know how long that's going to be effective for.
So is that efficacy rate apply regardless of manufacturer? So if you got J&J versus Pfizer versus Moderna, that 90%
appears that
efficacy?
The mRNA vaccines, in particular, the Moderna and the Pfizer vaccine, are more effective than the viral vector vaccines. The viral vector vaccine is J&J, so it does appear that those vaccines, the mRNA vaccines, are more effective. It may be simply because we get, the standard approach is to give 2 doses of the mRNA vaccines and only 1 dose of the J&J vaccine. And so it may simply be that we need, those 2 doses up front, regardless of what vaccine you get. And indeed, the CDC and the ACIP, the Advisory Committee on Immunization Practices, modified their recommendations with J&J to the point where they said that you now need a second dose at 2 months, suggesting that, in fact, up front, you may need 2 doses of the J&J vaccine to get an effective longer-term protection. That makes sense to me, just from what we understand about other vaccines.
Yeah, there's been lots to talk about. Let's talk about the booster, right? Lots to talk about the booster this year too. So can you share, how does the booster shot improve protection, and when should you get a booster shot?
So the booster shot, and this is sort of the naming nomenclature game that we're sort of struggling with, is the difference between a booster shot, a third shot. Is it part of your primary series or not? We don't, we got to get the words right. But if you think about it, most of us don't remember. But when we got our polio vaccine, we got 4 doses. If you happen to get your hepatitis B vaccine, you may get 3 doses, depending on which vaccine you get. There's a new vaccine for hepatitis B that's only 2 doses. But the point being that lots of vaccines require multiple doses to give you your primary series. So it seems, although others haven't stated this, it seems to me that the primary series for the COVID vaccine is 3 doses. And so we're learning this as we go. And so what we learned was that over a 6-month period of time after your 2 doses, in particular for mRNA, you really start to drop off your level of protection. And the 3rd dose induces, or your booster dose induces, a vigorous response that's even greater than your first 2 doses, which is very typical of what we see with other vaccines that get multiple doses. So it appears that the primary series for coronaviruses may actually, or at least these versions of the vaccine, may really require 3 doses. So the booster dose, in my mind, is completing your primary series. And the real question is, are we going to need sequential dosing, kind of like you get with a flu shot or a tetanus vaccine, where you get follow-up doses of vaccination to maintain your levels over an extended period of time? So the booster or 3rd dose is really what you need to maintain, to get your primary vaccine protection to an adequate level that you have longer term protection, longer term still to be determined because enough time hasn't passed yet.
All right, so to clarify, we're saying the booster, there's no difference between the booster and the third dose. They're one and the same, correct?
In general, that's true. There are nuanced differences of that. So, you know, if we wanted to, in the jargon that's been used by the Advisory Committee on Immunization Practices, they have been labeling the dose in the immune compromised host. Somebody who has a transplant, you got a kidney transplant, a heart transplant, and you got a third shot. They were calling that your third dose, as opposed to someone who does not have an immune compromised state, who gets a third shot. As opposed to calling that the third dose, they were calling that the booster shot. It's still the same thing. It is another dose of the vaccine, and parsing these words is adding to confusion. It's a third dose. It completes your primary series. You need to do that. And whether or not we need additional doses a year from now, or every year, like with the flu shot, or every 10 years, like with a tetanus shot, remains to be seen. We don't know that yet.
Okay, so when do you get the shot? When do you get the booster or
Third shot? When do you get it? You should get it somewhere around 5 months after your first 2 shots.
Okay.
Now,
So
they say 5 months. If you get it at 4.5 months, or you get it at 5 months, or you get it at 6 months, but somewhere in that time period or later. I would prefer that you don't get it later, but if you didn't get it at 6 months, get it at 7 months. If you didn't get it at 7, get it at 8. But ideally, you should be getting that third shot somewhere around 4.5 to 5 months or 6 months, somewhere in that time period.
okay, so let's say you got your first 2, you got your first initial series, and then you get COVID, right? So when, after getting COVID, when do you get that booster shot?
You have to be fully recovered, so don't get it when you're sick. And once you're recovered, 30 days. So previously, I generally sat on a little bit longer side, I would say 90 days. But at the moment, and that may change, by the way, but right at the moment, I've said 30 days. And in fact, actually, you know, in the beginning of the Omicron wave, we were really pushing the 30-day window. And the reason for that was because the Delta infection that folks might have had was not providing protection for Omicron. And so we were pushing that 30-day window because we knew they weren't going to be protected for Omicron, and we wanted to get a boost, get a vaccine dose in so that they would get additional protection for Omicron. Now that Omicron is the predominant variant, and that variant probably, don't know for sure yet because it's only been 6 weeks, but that variant probably provides you protection for another Omicron infection. But what we don't know is whether that infection with Omicron is going to protect you for the next variant. Mm-hmm. We just don't know. And we don't know how quickly that may or may not happen. And so I think generally we've adopted the position better to be a little bit more safe, given how quickly this virus has shown us it can change and wreak havoc, than to wait and sort of be behind the 8 ball. So generally, we've been saying fully recovered in 30 days.
Okay, so I want to clarify on fully recovered and what that means, because earlier we talked about some people coming down with COVID and being asymptomatic. So how do you know if you're fully recovered?
You feel well. I mean, that's the way that I look at it. There's no test for that. And so I think that it's important that you feel well. If you're still congested, if you're still coughing, if you're still overwhelmingly fatigued, you're not recovered. You may have a little bit of fatigue, but if you're overwhelmingly fatigued, you're not recovered. So you need to be feeling kind of like yourself.
Okay. Now, Breakthrough, we hear this a lot, this word, right, has been used to describe COVID cases among individuals who were fully vaccinated. So is that the correct term to use? Doesn't that imply failure?
Yeah. I think that that's part of the challenge of the discussion points along this whole road with COVID is what's the right word to use when you've had a vaccine and you still get an infection with the disease that you were vaccinated for. Breakthrough in and of itself simply means an infection despite having been vaccinated. It doesn't imply failure. And so if the term breakthrough implies failure, then we should come up with a different term. I prefer to describe it as an infection despite vaccination. Nothing is 100%, as I mentioned. Even when you had the ancestral vaccine and measured it against the ancestral strain of the virus, and it was pretty effective at preventing infection, let alone the issue around serious illness. It was about 90%, 95% effective in preventing infection. It wasn't 100% though. So some people still got infected despite a vaccine that was very effective for preventing infection. They still got infected with the ancestral strain because it wasn't 100%. Nothing is 100%. So, that doesn't mean that it fails. It simply identifies somebody who got vaccinated and then got infected. Now, breakthrough itself or infection despite vaccination, again, can run the gamut of what we described earlier. You can be asymptomatic, have no symptoms, feel perfectly fine. You can have a mild illness, or you can have one that's you're a little bit sicker, but it's pretty unlikely that that breakthrough or that infection despite vaccination will make you seriously ill. So that's the thing that's characteristic about so-called breakthrough infections, is that they're generally not, you're not very ill with breakthrough infections, except in unusual circumstances where you have a transplant, you have leukemia, and your body didn't respond to the vaccine. That's very different. That's a really important distinction, because a lot of folks look at that person and describe that as a breakthrough. Well, that really is probably a primary failure of vaccination, because you had a condition that prevented you from responding to the vaccine. That's very different than a typical breakthrough case.
So, and that probably goes, what you're saying probably goes along with some of the statistics we're seeing in the county, right? I think it was reported anywhere between 75 to 80% of Somerset County residents are vaccinated. And what we were seeing is those in the hospital, right, who were vaccinated may not have gotten that booster, right, that third dose for the full immunity, but they were only here, as you said before, for only a few days. So to your point, it's not necessarily failure. It protected severe illness.
Correct. I mean, and the other point that you were kind of alluding to is that the folks that are in the hospital who have quote unquote breakthrough infection and may be seriously ill even, are those individuals who have these compromising situations. So is that really a breakthrough infection, or is it simply the inability, and we talked about this earlier, that person's biology doesn't allow them to respond to the vaccine because they've gotten chemotherapy, they're on medicines to protect their transplanted organ, they have leukemia, they have some disease process that prevents them from responding to the vaccine. That's a very different patient than the typical patient who has a quote breakthrough infection.
Okay. So now, along with the vaccine, there's been some good news on the treatment front, right? The FDA recently gave us emergency use authorization for an oral antiviral treatment for COVID-19. So can you tell us more about that, this treatment, how it works, and who's eligible for it?
Yeah, this is great news. It's very exciting, actually, and I hope that they move quickly to make it fully FDA approved, because at the moment, it's still in this cumbersome process of what we call what's being called emergency use, or EUA, approval by the FDA, and so that makes it a little bit more cumbersome. But it was two different drugs that were approved. One was by Pfizer called Paxlovid, and the other was by Merck called Molnupiravir. And so these are what we call direct acting antivirals, direct-acting antivirals. We shorten that to DAA. The way these drugs work is they work by interfering with the life cycle of the virus. So they actually go, you take a pill, they hunt down the virus, they block the virus from reproducing itself and prevent it from causing damage within the person taking it. They work very much like other drugs everyone may be familiar with. So for example, Tamiflu, a drug that a lot of people are familiar with that is used to treat the flu or influenza, is the same thing. It's a direct acting antiviral drug. It blocks the life cycle of the flu virus and prevents the flu virus from doing damage to the human. Same thing goes with a drug called acyclovir or valacyclovir, a drug that's commonly prescribed to treat cold sores. And so cold sores are caused by herpes simplex, and we use direct-acting antivirals to treat herpes simplex. Many examples of direct-acting antivirals: HIV medicines, hepatitis C medicines, hepatitis B medicines. We have lots of direct-acting antivirals now that we use for lots of diseases. And this is just science's first step into the arena for some direct-acting antivirals. Both of them are effective. Paxlovid, the one by Pfizer, is more effective than molnupiravir, the one by Merck. Paxlovid is really amazingly effective, almost 90% in protecting people who took the drug from having the need to be in the hospital or succumbing to the virus. Molnupiravir, not quite that good, 30% in protecting against serious illness or need for hospitalization. The key principle in using these drugs is that they have to be given early. They have to be given early. That means within the first 5 days of being infected. That applies for Tamiflu with influenza. That applies for acyclovir with a cold sore or herpes simplex. And so this is not news. It's what we do all the time when we treat viruses with direct-acting antivirals, and it's true for these drugs as well.
Okay, and just to clarify, how does that differ from a remdesivir or a bamlanivimab? And that is that after
or
they
what?
have,
Or what was the second?
bam. I'm just going to call it
bamlanivimab. Bamlanivimab.
Thank you.
So remdesivir is a direct-acting antiviral. So Paxlovid and molnupiravir are direct-acting antivirals. So is remdesivir. But remdesivir doesn't come in a pill form. It only comes intravenously. And so remdesivir has really only been available for people who were in a hospital or had access to being treated intravenously. Molnupiravir and Paxlovid make direct-acting antivirals available to anybody who can swallow a pill. As regard to bamlanivimab, which is one of the so-called monoclonal antibodies, it's important to note that bamlanivimab, as well as the other monoclonal antibodies that have been available up through, say, December, are no longer active against the Omicron variant. And so they're no longer available. The FDA just rescinded their availability. And so you can't use them, shouldn't use them, can't get them. But a new monoclonal antibody is available called sotrovimab. Sotrovimab, we're going to make you say that name. So sotrovimab is available, and we can use that to treat Omicron. These drugs, again, are intravenous only. They're antibodies. They're not direct-acting antivirals. As antibodies, they search out for Omicron, they bind it up and prevent it from doing damage. The antibody is directed towards a structure on the surface of the virus, kind of like a lock and key phenomenon, and it prevents the virus from doing damage. But it's an antibody, it's an intravenous medicine, it's not a direct-acting antiviral.
Okay. I just have a few more questions, and then I want to open it up to the audience. So there's also a pre-exposure prophylaxis now available for patients who are high risk. So can you tell us more about this and who's a candidate for that?
So that's Evusheld. We actually had pre-exposure prophylaxis medications available for the earlier variants, Delta, for example. We were using the Regeneron monoclonal, and the one that you like to say, bamlanivimab monoclonal.
That is a
We were
mouthful.
we were using those in the Delta wave as prophylaxis or pre-exposure prophylaxis. They don't work for Omicrons. That's not available. The pre-exposure prophylaxis you're alluding to is called Evusheld, and that is available. Not quite as effective against Omicron as were the Regeneron or the Lilly monoclonal for Delta. So yes, it's available. It's available for people who have compromised immune systems, like we've been talking about, transplant, leukemia, lymphoma, on chemotherapy. And it's available as an intramuscular, into the muscle shot that is given as 2 separate shots once every 3 to 4 months. So it's available. It's of some benefit. It's not a slam dunk like the earlier monoclonals were in regard to Delta, but it does offer some additional, protection for those people who are compromised.
Okay. So one of the other things that has changed since the start of the pandemic is the greater availability of testing, including the home test kits, which are now covered by insurance. So how long after you are exposed to somebody with COVID should you wait to use a home test kit? And then how accurate are the home test kits? And what should you do if you test positive? Do you repeat the test? I know I'm asking you a ton of questions if it's negative. So let's start with the first one. How long do you wait to get to use that home test kit after you're exposed?
I'm a huge fan of these home test kits. I think that we've struggled a lot with availability of test kits. Hopefully there'll be more available. We're watching the curve. The epi curve in New Jersey looks really favorable. We're down to under 5,000 cases 2 days in a row. If we follow the same trajectory, by the end of the week, we may actually be under 2,000 cases. If that's true, our need for test kits is going to drop dramatically. It has already dropped dramatically. But that being said, I'm all about testing. We don't do enough. We weren't doing enough testing, and I think that we should test more. So everybody test. But that being said, how do you decide when's the right test to be? When's the right time to be tested? Generally, if you feel well, 2 to 3 days or thereabouts after you've been exposed would be the soonest you would test. The incubation time period for Omicron is shorter than Delta and some of the other strains. And so therefore it's going to move more quickly, as we've witnessed, frankly, through a population and through you as an individual. So once you've been exposed, if you think you've had a significant exposure, don't test day 1 or day 2, but the end of day 2, day 3, that's when you want to think about doing your first test if you're asymptomatic. Now, if you have symptoms, test. Don't wait for, if you feel bad and it's early on day 2, test yourself. If you feel bad and it's day 1, test yourself. There's no reason to wait if you're not feeling well. But if you're asymptomatic, have no symptoms, test at day 2, 3, probably day 3, and then test again at day 5 to 7. And if you're negative, you probably didn't get Omicron. As far as the reliability of the test, how accurate is the test? It's pretty accurate. The challenge with testing, if I had a swab, I'd illustrate how you have to do it. But doing the test on yourself, particularly if you've not had a lot of biology or anatomy classes, can be a bit challenging because you got to get the swab in the right spot. And a lot of people, when I watch them doing their self-tests or self-swabs, they're working hard at trying to get an adequate test, but they're actually not getting the swab exactly in the right spot. So the test and the accuracy of the test is dependent on getting an adequate specimen. And to get an adequate specimen, you have to get the swab in the right spot. And so that's part of the challenge in the accuracy. So you've heard about the accuracy of the test. Some of the accuracy of the test is related to how you sample. Some of the accuracy of the test, particularly with the Omicron variant, may be related to the nature of its disease or its biology. It seems to start more in the throat, maybe. We're not absolutely certain about that. And it ends up in the nose a little bit later. And so therefore, it may be that if that's true, swabbing the nose, particularly if you're not as facile on how to do the swabbing, can limit the accuracy. Some are advocating swabbing the back of the throat in addition to swabbing the nose, although the test is not approved that way. So I think that the test is extraordinarily accurate. There are some limitations because of the ability of adequate sampling, and there may be some limitations because of the nature of the Omicron variant. But if you don't feel well and you test and you're negative, particularly if you had an exposure, it doesn't mean you don't have Omicron. It doesn't mean you don't have COVID. It could mean that the test was wrong. So please retest yourself. And if you're sick, don't go out. Even if you have a negative test, getting a negative test if you don't feel well doesn't mean you can go out. It means stay home. Maybe the test was wrong. Wait till you're better and repeat your test the next day.
And what should somebody do if they test positive?
If you test positive, stay home for sure. If you're sick, stay home. But if you test positive, stay home. The standard quarantine, the standard isolation period, rather, I should say, because the right word is isolation, not quarantine. The standard isolation period when your test is positive is 10 days. So 10 days of, once your 10 days are up, you're free to be out and about. Now, there is some controversy or confusion around this because the CDC changed its guidance to say that you can be out and about after 5 days if you're feeling better. But the caveat is you have to know how to wear a tight-fitting mask. What that means is, do you know, have you been taught, are you familiar with wearing an N95 or equivalent mask to prevent any air from escaping around your mouth? So here's an N95 mask. Many of you have seen them. You got to know how to put it on properly so that no air escapes around the sides of the mask. If you don't know how to put it on properly and you can't be assured that there's no escape of air from around the mask, then wait your 10 days so you're no longer contagious. So that's the way we look at it.
Well, and since you brought it up, let's talk masking, right? There's been new CDC guidance on the best types of masks to use to protect against COVID-19. So how effective are the masks and which ones are the best and why?
So I just happen to have some masks here, right? And so they talked a little bit about cloth masks are clearly not as effective as some of the others. This is a surgical mask. It's actually multiply. This is a pretty effective mask as it relates to, day-to-day use. But you can see that even if I put it on here, my glasses will fog up. And many of you who have glasses know that when you put these on, you're always using your fingers to try and block the air. But also, if you look here, this isn't a tight seal. There's not a tight seal here, and there's not a tight seal under here, and there's not a tight seal here. So what this means is that air is escaping away from me. If I have an infection, I'm contaminating the air around me. And because Omicron is so much more contagious, that air is contaminated with Omicron if I happen to have an infection. This is an N95 mask. They're more challenging to put on. In the hospital, we're fit tested. And so when you put this mask on, it creates a seal up here. It's tightly fitting here. You can see it indents my skin on either side. And when I breathe, and if I'm wearing my glasses, they generally don't fog up unless the mask is old and it's not properly fit anymore. And so this mask, when I breathe, all my air goes in and out from the mask. And so it acts as a filter so that if I happen to have COVID, or if you're in an environment where COVID exists, since the air is going in and out of this filter, it prevents the air from being contaminated from me, and it prevents the air that I breathe in from containing any virus that might be in the air simply because it filters it out. So these are the masks that they're talking about that are most effective. N95 masks, KN95s are not bad, but they're way better than this type of mask. And all of these masks are better than the fabric masks that we've come to use a lot on, that I see a lot on people.
Okay, thank you. So I want to open it up to questions from our audience. We have a lot of them on posted already, so I'm just going to start to dig in. So have you seen that all vaccines affect inflammatory issues like arthritis, making it a little worse for a short while after receiving the vaccine? If so, can you explain why that happens?
Well, with almost any vaccine, there is an immunologic response. That's what you expect, even if you don't. And Serena and I were discussing that some people don't have a vigorous response to the vaccine. So maybe their immunologic response didn't seem quite as vigorous, but they did respond and they're protected. That being said, some people just get more achy when they get a vaccine. As I mentioned, when I got my shingles vaccine, I was really achy. I was down in bed for a couple of days because of the reaction to that vaccine. I had my tetanus shot the other day. I had my 6th grandchild. I didn't have it, my daughter did. But I got a vaccine for pertussis because you have to be protected for pertussis. So I was achy for a little bit. Wasn't quite as bad as my COVID vaccine, and certainly not as bad as shingles. But when you have those reactions to the vaccine, it can make inflammatory conditions a bit worse. So whether you have arthritis or whether you have other inflammatory conditions, myositis, it can make those a little bit worse for a couple of days. But generally, that's the key point. It's a couple of days. So you take some Tylenol, take an anti-inflammatory for a day or two, and you'll get back to your baseline. So that's just a normal immunologic event that happens with lots of vaccines. It's not specific to the COVID vaccine.
Okay. Another individual writes, both she and her husband received a positive COVID, I guess tested positive for COVID around the same time, but totally different symptoms. Could this mean that they suffered from 2 different variants of COVID, or are we back to the human factor?
Yeah, no, absolutely. Every one of us is again, a biology experiment, and we're all unique. We each got our DNA from our moms and our dads, and each one of us are going to respond differently. And you're going to be different than your brothers and sisters, even though it'll be somewhat similar. I gave the example of my brother who had a very different reaction to his vaccine. And the same thing applies to getting COVID. The manifestations will be very different person to person. It's just the nature of biology.
Okay, so this is a follow-up to that question. Again, you mentioned just biology that determines how you will react to the vaccine. Why then does someone get different or lack of reactions to one, but maybe not the other 2 they receive? I think we
I wish I could give you a specific answer that other than biology, but it really is the body's immune response to the vaccine that causes the reactivity that we get. The term that we use is reactogenicity. So the reactogenicity, it just varies from day to day, shot to shot. It's hard to know what's going on internally in each of us on the day we get those shots. And the reaction that you had to dose 1 doesn't mean that you'll get the same reaction to dose 2 because things have changed. Your immune system has already been exposed once, and that change could either result in a more vigorous reactogenicity response or a less vigorous reactogenicity response. It's almost impossible to predict that. It just, I will say that personally for me is kind of about the same, but boy, you're absolutely right. It varies from person to person, and it's hard to understand why that is, but it's the nature of biology.
Okay, so are those who are not getting the vaccine the ones who are continuing to add to the potential variants rolling out in the future?
That's a really great question because, as we've already discussed, about 50% of the folks are vaccinated. So there is a concern that persistence of the virus within a community is what allows the evolution of the variants. And if we get a variant that is able to fully avoid immune surveillance, it won't matter whether you're vaccinated or unvaccinated, because as long as the virus is able to replicate, it can mutate, create a new variant that could cause other problems. So although in large part within the communities around the globe, it's the unvaccinated in which we have the majority of the disease, there is still enough infection that's occurring within vaccinated folks that we have some concern that a variant could evolve within the vaccinated community even that may become problematic. We really don't know the answer to that. I think a lot of us hope, and it remains to be seen, a lot of us hope. We don't know because we just don't. I always say the virus is in control. But a lot of us hope that as this virus mutates, the more it mutates, the less angry or aggressive the virus becomes. And as long as that's what happens, all right, well, then we're at risk for getting a mild illness or a cold. And yeah, maybe that's what we're going to continue to see. But we honestly just don't know the answer to that.
Okay. So any updates on a possible fourth shot for Pfizer or Moderna? So this person.
Well, I think that the question is, and you're sort of looking at this because I'm now 6 or so months, 7 months out almost from my third dose. And should I be thinking about getting a fourth dose? So I think about it. I haven't made up my mind. I'm not convinced that that will add anything. What we've learned from the experience in Israel, and I've said before on this forum, Israel is really the champ in leading us relative to what to expect for vaccination. And they've deployed a fair number of fourth doses. And what they've noticed is that the immune response on the fourth dose is not as dramatic as what we've seen on the third dose over and above the earlier doses. You're not seeing that kind of dramatic improvement. So we're not getting a really remarkable change in immunity after a fourth dose. And so the question remains is, one, did they give it too early? 2, do we really need it? 3, do we need a different type of vaccine on a fourth dose? And I think it's just too early to know that. So I'm not sure, except for the immune compromised individuals, we're not going to be able to, really know about the fourth dose until more time passes.
Well, and that's probably along the lines. Can you predict how many more waves we're going to have?
No.
Right.
Don't know. I hope this is the last wave, but if you think we're going to have more waves, I don't know how many. Do I think that it's likely that this is going to continue to be something that we're going to have to deal with? I do. Do I think it's going to come by in waves? I just don't know. I wouldn't doubt that it's just sort of this chronic, annoying virus that is just going to be around that's going to cause people to not feel well. That's actually what I'm hoping for, but it remains to be seen. We really just don't know.
So when lab work shows antibodies still present more than 1 year after having COVID, doesn't that show that natural immunity gives equal or better protection than the vaccine?
Well, the problem is we don't have a measure that we can use in the general laboratory that evaluates immunity. We just don't. What we have is a measure of antibody. Now, that may be a surrogate for immunity, but we don't have a way to quantify that surrogate. And so that's number one. But number two, and it's really important to understand this, and I alluded to it earlier, if your earlier infection was with alpha or delta, we also now know that that's not going to protect you for Omicron. That we learned. And in fact, it was pretty telling. We learned that pretty early because those folks who were unvaccinated, who got Delta in late November, early December, as Omicron was starting to climb up, we saw a fair number of those folks come back to the hospital 3 weeks, 4 weeks, so 5 weeks later, who had another infection, most likely with Omicron. And so it's really unclear relative to the protection that you get from a natural infection that you're going to be protected with the next variant. And so because of that, and because what we do know is that vaccine after natural infection induces the broadest and most complete immunity, that's almost like winning the lottery. If you want to think of the vaccine protection lottery as being, something you'd like to achieve, the best way to achieve the broadest protection is to get vaccinated after having a natural infection. It's very clear that that level of immunity is really the broadest and most effective across all the variants. We now know that. So I really encourage people who've had the disease to actually get vaccinated. There's no downside to that.
So is there any blood level of immunities that individuals should have for which they could be considered well protected?
No, we don't have a test that measures that. So the answer is no. I just don't know. There may be, but we don't. The test that would be ideal to evaluate that would be called neutralizing antibody titer. We don't have a test for that. So since we don't have a test for that, I have no way to counsel people about that level.
Okay. Now, what happens if somebody who gets a booster and unknowingly has COVID, meaning they're asymptomatic, and they get that booster? What happens in that case? Have you seen any cases like that?
Yeah, that happened a lot with the with this last wave because Omicron was just so aggressive in causing infections. Nothing happens. That it's not like the booster is not going to at that point have a material impact on your Omicron infection. It's an event that occurred. There isn't going to be an upside or a downside to that.
Okay. So is there any specific study that shows excellent efficacy of wearing masks, showing decrease in COVID infection rates, decreased hospitalizations, or decreased severity?
Well, the studies that have been done with masks have really looked at the ability of masks to protect against not only COVID, but other respiratory viruses. It's pretty clear, whether it's COVID, influenza, tuberculosis, measles, it's pretty clear that masks have a dramatic impact on the likelihood of somebody acquiring a virus that's passed by the respiratory or airborne route, which is how COVID is passed. So we know from lots of experiments over many years that, for example, N95 masks are highly effective in protecting against getting respiratory viruses, and more recently, in particular, with COVID-19. So a well-studied phenomenon that is the protection of N95 masks for respiratory viruses. Regarding the severity of the infection, should you get it, I'm not aware of anything that would suggest that the type of mask impacts the severity, except to say that if you're wearing a mask, you're less likely to get the disease. So if you don't get the disease, you're not going to feel sick. But outside of that, that is actual prevention. There wouldn't be an expectation that a mask would otherwise affect the disease.
Okay. Now I know we're at the top of our hour. Do you have some time for a few more questions?
A couple of minutes, but that's it. I'm going to have to run.
Okay. So here's an interesting question. Why not treat people with pills before they get sick? Many old and new pills in the market can prevent hospitalization, not only vaccines.
Yeah, no, that's a great thought. Those studies are being done. We do that with Tamiflu. We do that with herpes simplex or cold sores. And so I wouldn't doubt that at some point we'll see that that's true. But the way medical science advances is that we have to test the hypothesis. I think that's a very reasonable hypothesis and would think that that's a likely utility of those drugs at some point in the not too distant future. I hope that that is true. Agree with that.
Okay. So again, where do you go to buy tight-fitted N95s and K95s? So, and just to clarify, are you recommending that community members use the N95s or KN95s?
Those masks are the best masks to protect you. So if you have access to them and you know how to wear them, there's not a question, hands down, those are more effective than the other masks that are available. KN95s, K95s, KN95s, or KN94s tend to be, I don't have one here, tend to be easier for the general public to use. If you're not familiar with how to use an N95 mask, you might be better served with a KN95, which is not all that much different from a protection level. You can get them, I mean, they're available all over the place. The problem is that the reliability of some of the K95 masks, because it can be challenging because there's a lot of counterfeit producers, and so that's part of the challenge, and they're not NIOSH approved. And so here in the US, there's no regulatory body grading them. With regard to the N95s, there is a lot of that, and they all have a number and a label on it that provide reassurance for you. But all of them are better than the cloth masks.
Okay. Do these vaccines cause any infertility? Because I know that's always a big concern for young families. You just mentioned
there's absolutely no risk to fertility relative to these vaccines. That's been looked at extensively. At this particular point, it's now clear that the risk of COVID to fertility is far, far, far greater than any concern related to the vaccine. And I can tell you with certainty from personal knowledge, my daughter has had 3 doses and she just delivered a healthy boy. And my niece had 3 doses and she delivered a healthy boy. So personally, I know of at least 2 anecdotal cases where that was true. But I think that the point is that this has also been extraordinarily well studied. Remember the biology experiment I mentioned. There's been hundreds of millions of doses in the United States. Many of those doses went to women or men who were thinking about conceiving and or who were pregnant, and no signal to suggest that the vaccine induced infertility or caused problems with pregnancy exists. And so as a result of that, the ACIP and the two professional organizations for the OBGYN doctors have both strongly recommended vaccination.
Okay, and last question, I'm going to try to combine two. This is regarding the Paxlovid. So Paxlovid was being promoted as very effective, right? And I do hope it pans out. However, it rolled out, there's a lot of information about side effects. So are there patients who would not use this medication? And once again, does it help to eliminate moderate to severe disease?
Right. So ideally, you would use this drug early within the first 5 days of an illness to prevent the development of moderate or severe disease. Paxlovid comes with a package, a warning about its drug interactions, because it's a class of drugs called a protease inhibitor, and it actually has two drugs in the medication. One is a drug called ritonavir, a drug we know well because we use it in our HIV patients, and the other is the actual active medicine called a protease inhibitor. Both of those drugs can block what's called the cytochrome system in the human body. And in blocking the cytochrome system, it can affect the level of other drugs in the blood. Because we have a lot of experience in using these drugs in our HIV patients, we have a very good understanding about those interactions. And so it takes a little bit of work, but you can work through the drug interactions based on our experience in the HIV arena using these drugs, because they're very similar, and have an understanding of how those drug interactions might or might not affect your patient. And so you could choose to use the drug with an understanding of what the risk is by virtue of what we call its metabolism in the cytochrome system. It's only for 5 days. Some options include interrupting certain drugs if you need to, adjusting other drugs if you need to, so that you don't get into a drug toxicity situation. But that's where that warning comes from. It's about the drug interaction issue. It is not something that we have no familiarity with. It's something we have a lot of familiarity with because of other drugs.
Okay. Well, thank you so much. And thank you for fielding all these questions. You gave us, the audience, a ton of great information that hopefully will be helpful to everybody in preventing, getting COVID. So really appreciate your time today, Dr. Nahass. So thank you all for joining us today. This is going to conclude our webinar. Again, a big thank you to Dr. Nahass for the wealth of information you've shared today. And please remember that the information shared here by our medical expert is not a substitute from advice from your own physician. If you do need a physician, please call 1-888-724-7123. And for more information about COVID-19, please go to www.rwjbh.org/COVID-19. On behalf of Robert Wood Johnson University Hospital, Somerset, thank you all for joining us today. Remember to wear your mask, wash your hands, wash your distance. When sick, stay home. And when you can, get your booster. Thank you all, everyone. Have a great day.
Thanks, Serena. Take care.
Bye-bye.